Hello, and welcome to this edition of the Cataract Specialist. Today, I've got the joy of interviewing a very familiar face to most of the cataract world, past president of the United Kingdom and Ireland Society for Cataract and Refractive Surgeons, the Webb's cataract doctor, Professor Paul Ursell. Welcome.
Hi, everybody.
Hi, Paul. Perhaps we could start by just you telling us a little bit about your consultant career to date, Paul.
So I became a consultant at Epsom St Helier NHS Trust in 2002. And I had a fantastic time. I just finished a few months ago, but I had 23 and a half years. I was clinical lead for my trust. I was head of cataract, head of audit. We got Medisoft before it became Medisite implemented. We set up lots of protocols to improve the amount of cataracts we were doing and the quality we did. Sort of doubled the amount of cataracts that the unit did over the course of the 23 years I was there. It was great. I really enjoyed it. I did a lot of training. There's quite a few people now who are in all sorts of different places around the place who are trainees who came through our hands. I kind of My philosophy about academia, because I still maintained an academic profile. So I did quite a bit of research when I was a trainee. So I wrote my PhD with John Marshall and David Spalton at St Thomas's on Acrosoft implants. You only know Acrosofts have got a square edge and that cuts down PCO.
Yeah.
Well, we were the people who described that first ever found out about it, which surprised everybody. Um, and then I became an academic, sort of in cataract surgery. I worked in Oxford as a lecturer in the university, and then I did a year's fellowship in Australia with Graham Barrett of the Barrett, calculators and all the Barrett stuff.
Yeah.
So I had quite an academic background, and I maintained that in a DGH. But my philosophy was is that I'm not going to do the high end, really intricate stuff, but I wanted to do the general stuff at a very high level. And that meant it was very conducive to training. So I really enjoyed back in the days before simulators, just taking people from a standing start and getting them to do their first cataract and then helping them to progress from doing the first cataract to their first 100 and then sort of helping them to progress to doing every cataract that came to the door, be it a hard nucleus, a small pupil at different stages. Um, and we had a whole training program that we set up at Epsom St Helier in the Sutton Eye unit to take people through that. And that was a really rewarding part of being a consultant, particularly in cataract surgery, is if you give a man a fish, he can feed his family. If you teach a man to fish or a woman, they can feed their family for their whole life. And that was really lovely, particularly when you see people who you taught, who you got got going and gave them a sort of a push down the hill and off they went. Now they're professors of this and, directors of that. It's really, really cool.
A
So,
lovely feeling. And where do you currently work now if people wanted to see you?
so I'm in full-time private practice now in Wimbledon at Parkside Hospital. So my clinic is about 500 meters from Centre Court, which is quite cool. And you get the odd Wimbledon type person come through the door, plus Southwest London. And then the other one's down in Surrey at Ashted Hospital, just off the M25.
Lovely.
And that's really enjoyable. You can put just as much interest and fun. It's not just about earning money, it's about running a business. And if you treat that in the same way as the rest of your NHS or academic or professional career, it can be just as much fun.
Yeah, indeed. Now, Paul, you've obviously had a life spent very much in ophthalmology. If you weren't an eye surgeon, what do you think you'd be good at instead if you had an alternative career?
Oh, Jesus. What would I do? I don't know. And I love being an eye surgeon. I mean, I just think of, I mean, I do a bit of public speaking and stuff like that. And I would say that of all the careers you can have, being a doctor is pretty much up there as one that society likes. If you look at all the doctors, being a surgeon is pretty cool. And we are surgeons, and it's who lay on hands. It's like the Old Testament or Gandalf. You lay on hands and people see. I mean, it's just insane. What would I do? I think I quite like analysis and understanding trends. So maybe something to do with figures, to do
Yeah.
with finance in that respect. But I don't think I could possibly do anything as good as what we do now.
I think we're all very glad you're an ophthalmologist. Now, having done tens of thousands of cataracts already, which part of cataract surgery still makes you hold your breath even after all this time?
The ones I really don't like are people with bad zonules. I hate it when they've got bad zonules. That's the one that's the technically I find the most tricky. Putting CNE rings. I mean, it's fun to do, but it's the one that you just think, oh God, this is going to be. I mean, a dense nucleus, small pupil, those sorts of things. They're fun. They're good fun. They're enjoyable. But when they've got zonular insufficiency, that's the one I don't like those.
I think we're all with you on that one. In general, how do you go about minimizing the risk to your patients? What do you do?
Well, I do a lot of speaking about this. We've got a whole project about resilience, about understanding risk, about how to create a mindset in yourself about how you do it. So we had the sports psychologist from the England rugby team come into theatre with us a few years ago, and he looked at the mindset of how you as a surgeon work. So to mitigate risk, you've got to understand it and you've got to look at the patient. So we published a big data analysis of what leads to a PC rupture, sort of leading on from the stuff that's in the Medisoft database, and how that can be used to scale a procedure from sort of 1 to 12, I think we had it as. And then each surgeon at each levels of their career pathway up to the first 400 cataracts could only do things within their pay grade. That was for trainees, but it certainly teaches you as a surgeon, right? Okay, I know this one is going to be tricky. I've got to be switched on for this. What the guy who was a psychologist taught us was, if you think about rugby, I don't know how much you know about rugby, but rugby is a hardcore contact sport with some very pumped up, aggressive individuals knocking seven bells out of each other. And then they have hot skills, which is, do I kick? Do I pass? Do I go? Do I tackle? What do I do? And you've got to do that at the pace. And then they have a thing called cold skills, which is like you've got to switch off the adrenaline and you've got to throw in at the line out, or you've got to kick for goal or whatever. And you've got to concentrate and focus. And then you've got to get back on it again and start knocking, the adrenaline out of somebody else. And how do they transition from one stage to another? And they use a lot of visual imagery to do that. And you see that a lot with swimmers are the same and golfers are the same. They're always trying to imagine themselves in a good place where they're not under pressure and they're not under threat, which is what we can do as surgeons. And the chap who was a psychologist was watching us as a group. And there was a whole melee of people. We had anaesthetists back then, and we had nurses and we had trainees and blah, 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 blah. And we're all, staff and hanging around talking about the stuff. And then he said, one of you will separate yourself from the group and you will walk into the corner or into another room and you will perform a ritual and you will focus. And then you change your appearance. You put on new clothes. And then you walk back into the group and you are then the surgeon. And what he identified is that moment when you're sitting basically at your sink scrubbing. And now most of us, I realize we're thinking about the case, but when you actually are aware that you're thinking about the case, you then can use that moment to really zone in. So we had put in our operating theatre signs up around the scrub area, just trying to enable you to calm down, to relax, to focus, try and understand what you need to do with the case. We developed a system of linear thinking. So a cataract operation is very linear. If you watch a complication, you don't just bust the capsule. Something happened way upstream, and this happened, and this happened, this happened, this happened, and then you bust the capsule. So we created a linear journey. So if you do each step properly, you're not going to end up in the vitreous. And the complication that went wrong here led to the vitreous loss. And if you stop those complications, you stop the vitreous loss. So keeping your eyes on a journey, which means that you focus on each step individually, and you try and do it as well as possible. So it starts with just positioning the patient. You get the patient positioned correctly, and then draping, and then putting the speculum in. Get that all wrong, you end up with a problem. But if you focus on that, get that right, and you focus on getting your section exactly right, and you focus on doing a rexis as good as possible, doing a big rexis when there's a difficult case is one of my sort of mantras that I say to myself and I say to my trainees. then you find that you get through the case without having bust things. Whereas if you find yourself being pushed around and buffeted by events, then you end up breaking the capsule.
Good training for life. Maybe we should get you to talk to the England cricket team at the moment.
think that I don't think I've got much to offer them.
So, Paul, I know you've done some research on this. Can you tell me a little bit about the link between dementia and cataract surgery? What have you learned from your research?
Well, yeah, this is a fascinating area. So I was a trustee of an organization called Seeability, which is a quite a large charity. It turns over about 40 million a year, and we look after about 400 people who've got learning disabilities and sight loss. And they're based in Leatherhead, near where I was working my NHS practice. And I became a trustee of that. And you realize how much work goes into caring for adults with complex needs like that who are vulnerable. And I thought, as an eye surgeon, I knew what I was talking about. When I went along to that, I realized I was very much out of my depth, and it was quite a steep learning curve. Anyway, from there, I segued into dementia and sight loss because that's kind of a similar sort of thing. And I was chair of an organization called Vision 2020's dementia subgroup. Uh, and now I don't actually do much research, but what I do is advocacy. Um, and it's a real unmet need. I think it's one of the areas in cataract surgery where we really have a lot of work to do. In most of cataract surgery nowadays, it's kind of done. We've sorted out complications. We've sorted out doing phaco. I mean, I started doing my training when it was the conversion between extracath and phaco, and it's been a 30-year journey. And phaco now is kind of pretty much sussed. Implants are getting so much better now. Delivery is getting very good with the independent providers. But the problem we have is people who live with dementia fall through the cracks in that service. There was a big research study done by the College of Optometrists with an NIH grant a few years ago called the Provide study. And they sent optometrists into environments for people living with dementia, so either at home or in care homes. And they just did a straightforward optometric examination. And they refracted them and they checked over their eyes and did a dilated examination. And they found that 1 in 3 people who were living with dementia were 612 or worse binocular. And that's really rubbish. And then the reason for that is 50% just had the wrong glasses on, i.e., they hadn't been to the opticians in the last year. And of the remainder, 50%, the reason why their vision wasn't very good was because they had cataract. So if you
Yes.
imagine that's effectively 75%, if they all had a cataract operation to make an emmetropic, they wouldn't have this problem. And that compared to the general population is a huge disparity. And there's lots of research that shows once you get a diagnosis of dementia, your chance of having a cataract operation goes down the tubes. We also know that taking cataracts out actually improves your care if you have dementia. So your chance of dementia progressing, your chance of actually being diagnosed with dementia if you've had your cataract out is so much better. We can also see dementia in the eye. You can stain tau protein, which is what the amyloid protein you get in Alzheimer's. You can actually stain that in the retina, and you can see changes in those CT scans. So it's a fascinating area. It's the area, I think, in cataract surgery where if you're a young guy or a lady or whatever person, I get it right, if you want to develop a research area, the delivery of cataract surgery and the impact of cataract surgery on people living dementia is an absolute unmet need that you could really get stuck into, and it would do some real good.
Now, obviously, the standard approach is to put a monofocal lens in such patients. Do you ever put premium lenses in them?
Now that's the $64,000 question. What you want to do is make them functional. So my mantra is it doesn't matter if you give them a GA. So GAs don't make dementia worse for cataract surgery. They do if you're having a hip repair or cardiac surgery, then definitely there is dementia will get worse. But a little sniff of gas for a 10-minute cataract operation is not going to make your dementia better. So giving people a GA is absolutely legit with dementia. You can and do both eyes do while they're asleep. That's just crazy. So what type of refractive outcome are you after? Well, you want to make them functional. So my view is that if someone is not driving, then give them -1. because then their world at arm's length is in focus. That means they can feed themselves, they can do the crossword, they can get on their phone and their iPads, they can do what they need to do. Plus, one of the big problems in dementia is falls, and particularly when going downstairs, that's why varifocals are no good. And if they're -1, that's about right for working out what to do going down the stairs. Should you use multifocals or EDOFs? That's a really hot topic, and there's been a lot of debate. My feeling is that you could, like I alluded to, you can demonstrate the impact of dementia on visual functioning because you get the tau protein and the changes in the visual cortex. If you get a lot of it, you get posterior cortical atrophy, but there's always something going on in there. You can also see dementia in the eye. You can see changes. There's a lot more normal tension glaucoma. So, just optic atrophy is that goes on in dementia than the normal population. So the eye is involved, as is the brain. Now we know on the other side of the coin that if you're putting a multifocal into someone, you often, a lot of time, rely on neuroadaptation, which is they come to see you a week later, it's kind of all right, but and then I've got a few halos, or yeah, I'm just doing it, and then you see them 2 months later, say, yeah, it's good. I got used to it now. It's quite cool. Yeah, I'm good. And that period of time, that's neuroadaptation, and that's been shown with functional MRI that there is structural changes going on in the brain and the visual cortex and the rest of the brain and the visual processing areas to mitigate the impact of the multifocal. Now, if your brain's failing, I am not sure you need the distance vision to be in focus, but you do need the near vision to be in focus. And if the brain's failing and you then lose your neuroadaptation that you have demonstrated you needed for the multifocals, potentially that's a problem. So my view is that distance vision, if you're not driving, is not a big deal in this population of people, but up close reading vision and this arm's length vision is. Therefore, there is a very plausible argument for using multifocals, but I think when you dig into it and you sort of contemplate it a bit, I think just -1 is where you want to be.
Very sage advice for all of us, I would say.
Mm.
Paul, do you foresee a future in your lifetime where cataract surgery will become completely robotic and autonomous?
Well, I think there might well be. I think healthcare is one of the last bastions of proper robotics. You look at assembly lines, factories, they're all robotic. You look at flying planes, that's all robotic. The pilot doesn't do so much. Healthcare is a much more intimate and personal type of industry. People want to know their doctors, they want to feel them and see them and engage with them. I think there's an emotional barrier. I think technically uh, it will come. Legally, I think there will be a lot of issues. We've seen that with the autonomous driving cars. That's taken a long time to get it going. But on the other side of the coin, you see the impact of the massive advances that have been done in technology nowadays, particularly AI. I mean, I use ChatGPT every day, and it's jaw-dropping how clever it is and how useful it becomes in your life. And that's over the course of the last 2 or 3 years. Give it another 20 years, you could see that happening.
Paul, what are your views on bilateral same-day cataract surgery under local anesthetic?
I think it's a great idea. I think that there was quite rightly a concern about it, and it's interesting. I learned cataract surgery in the days of extracap, and the guys who taught me had a lot of them learnt with intracap, and that was a very different operation. And there's lots of things that we do that are hangovers that we've been taught down from teacher to student to teacher to student over the years. So we have just stopped using post-op antibiotics because we don't need them anymore because we got intracameral antibiotics. Whereas 5 years ago, if you said, I'm not going to give antibiotics after cataract surgery, it would have been crazy. And I think that there's been an awful lot of the way that we practice our craft of doing cataract surgery that has been handed down over the years without being questioned. because that's just how we were taught and that's the way you should do it. I think that simultaneous surgery, there was quite rightly a very robust debate all around the world, particularly post-pandemic with the backlog of cataracts that we all needed to address everywhere, not just in the UK. And I think some very coherent and very well thought through research and arguments were made. But the proof of the pudding is in eating. We are now doing an awful lot of simultaneous cataract surgery around the world, particularly in the UK, and we haven't seen a great big tsunami of complications or lawsuits or issues. And I think that as a community, we've kind of accepted it. And there are still some areas where there's debate. But I think a lot of people will say, yeah, it's fair enough. We can do that. What about you?
I think it's wonderful. I mean, it's absolutely fantastic. Patients love it. Optometrists love it. It's just lovely to have balanced patients. And most of the old arguments were about potential refractive surprises, most of which aren't relevant these days. And I'm a great protagonist. My hospital, NHS hospital, actually was top of the league 18 months ago for doing the most bilateral cataract surgery in the entire UK. So we're very much believers in it. And it
Well,
works well.
I when this all came out, I ran a little sort of project. I thought I'm not totally sure how I'm going to play this and how I'm going to talk to people about it. And I wanted some data and some thoughts from people. And I thought, well, who are the people to ask? Is it people before they've had the surgery? Well, they won't really know about it. If I did bilateral or both eyes afterwards, they kind of, yeah, it's great, just do both. And I thought the best people to ask is in my practice, I do them 2 weeks apart. So I thought at week one, when you come back for your checkup, after we've done the first one, I ran a project where I asked 100 people if I could go back to last week. You've just had this done. I'm going to do that one next week. But if I went back to last week, knowing what you know now at 1 week, what do you want, one or two? What do you think the answer was
I
out of
imagine
100 people?
all dying to have it done.
50-50.
Oh, really?
Yeah. I was really shocked. I was thinking it would be the same. So, and I was really agnostic about pushing them one way. I just said, go and fill out this form, sit in the waiting room, fill it out, leave it with the receptionist. So I didn't coach them in one way or the other. And there was lots of things like, well, I didn't quite like, putting drops in, or I didn't quite like the pain or whatever. I think I would have preferred to have two, having just had one done. And it
Yeah.
was fresh in their minds a week later. So my view is that if you're getting over 50-50, maybe you're shoving a few more into it than actually you would want it.
Yeah, that makes sense, I suppose. Yeah, most people seem to prefer their first eye experience to the second eye. I'm sure there's a big psychological effect there.
I mean, I think we're learning a lot about this, about how to do it. So always make sure the trainee does the first case, not the second one,
Yes.
because why the hell did that one take so long? What are you doing out there? I mean, we are evolving this, but I am very agnostic. I say this is the deal. You can have one, you can have two. What do you want to do? And you see people process it and cogitate, and some will go one way, some go the other. But I mean, I think actually it's probably going to be a bit more than 50-50 now. Probably
Now,
75.
you mentioned the inconvenience of eye drops. What are your views on so-called drop-less routine cataract surgery that some institutions are pressing at the moment?
Yeah, I mean, I'm just about to introduce it in my practice. I'm having a bit of pushback from the pharmacists about pricing structures and the fact that is getting our hands on the appropriate medication because it's all been bought up is a problem. I think the Shorstein papers from Kaiser Permanente are very plausible, and they have got big data and they're well constructed and they show quite a powerful argument. I certainly think that it's again, patients like it, and if patients like it, you've got to really ask yourself, well, why should we not do this? If they think it's a good idea, we're working on their behalf unless there's any particular reason. I think again, it's a bit like bilateral. We'll dip our toes in the water. There'll be a few little bumps on the road. Things will happen, and we'll learn. But I suspect, give it another 5 years, it'll be a standard thing across everybody.
Okay. And what aspects of eye surgery or cataracts in general do you think the public understands the least in your experience?
Um, I think they understand the least is once you start getting index myopia, and you're needing to get a new pair of glasses, effectively you're on the takeoff ramp for a cataract operation. And unfortunately, Why spend another 5 years churning around lots of pairs of glasses? Even though you've got good quality vision, there is an element that we need to shift that goalpost and say, yeah, but the odds are once you get to that stage, you're probably going to need it doing. Why not have it done now rather than wait? I think that's one of the things that people just don't understand. They certainly don't understand about implants. The amount of times I speak to people and saying, well, I could get you out of glasses. Really? What's all that about then? And they have no idea that this is an option to them.
It's a complicated world, isn't it?
Yeah, well, I think that there are, it's just not commonly known, and is commonly known to the people who've had the surgery, but the ones coming through from 50, 60, the message doesn't get to them because the 70, 80-year-olds will know, and they don't, the 56-year-olds don't sort of get the message until after what they've done.
Now, talking of lens implants, here we are at the end of 2025. If you, Paul Ursell, had to have cataract surgery yourself tomorrow, which implant would you choose to have implanted and why?
Well, I have got a very strong family history of glaucoma. So I probably would like to make sure that that in my later years was an issue. So I think probably a trifocal, if you got glaucoma like some of my relatives have had, you probably wouldn't have. If it wasn't for that, I'd probably go for trifocals. I do monovision. I think monovision is fantastic. I think the stories about loss of depth of field don't happen to work for me. So I think a monovision toric correction with either a mild EDOF or a lens with the appropriate spherical aberration, depending on what maybe my corneas have come up with, would be the right one for me.
So pretty much any lens at all. That's a very diplomatic question. I
Well, I think that in some respects, it's like asking pilots, do you flying Boeing or Airbus? I
understand.
just get in the plane, don't I? And I think that there's horses for courses, and there are particular lenses that work in particular situations. But most of the time, pretty much all the lenses work in all the people.
Yeah. And who would you choose to be your surgeon, Paul? You've probably seen a few during your
You want
time.
to give you a name?
Yeah, why not?
I have no idea. I think most of us rack our brains over that. I certainly have. I mean, I don't do relatives. I've had plenty of relatives come and ask me. I just find that a little bit too close to the knuckles, so try to not do relatives myself. Um, who would I ask to do? Probably one of my trainees who I liked and who I felt. And you want some at the right stage in their career. You don't want. I mean, I've certainly gone through a journey with my own career where you make different types of mistakes and make different types of decisions at different stages in your career. And I think that someone in their mid to late career is probably the person you want.
Rather than someone fresh out of school.
Yeah. Because you haven't made enough mistakes. I mean, you gotta make a few mistakes to learn, and that's not something you do as a trainee.
And the old adage is you've got to learn from the mistakes of others because you won't have time to make them all yourself.
Well, you got to spend 10 years learning how to operate, 10 years learning when to operate, and 10 years learning when not to operate.
Sounds very, very sage again. Paul, thank you so much. I hope you've enjoyed yourself and thank you for talking to me.
Simon, it's been an absolute pleasure. Delightful to speak to you.